So we're going to talk about underwater in the sigmoid colon. I think of the things that have changed practice and have made a big difference, this is certainly up there. I have had just come off the back of a very interesting conversation in the UK about introducing this into normal practice. And you can be sometimes misled to think that everyone is keeping up with you. And I was shocked to find that actually in the UK, we're just having a discussion now about integrating this into our training programs. And I tried to say to them yesterday, this is not a rebellion, this is a revolution. This will change your life. And hopefully this talk will demonstrate why. So why are we using it instead of the standard gas or CO2 insufflation? Well, the first thing to say is we'll make your life easier. Secondly, it will clean the colon as well as helping you intubate the colon. And as we've heard many, many times over the last day or so, you need everything clear. To clear you need a clean stomach, you need to clean everything, and the colon's no different to that. I think critically for trainees, and probably for your own routine practice, we can reduce pain by using water. So for those of you who are practicing sedated colonoscopy, which is my practice, this becomes an important factor. And obviously, if there's less pain, you use less sedation. I think importantly, and what we will be discussing throughout the day, is the detection of significant lesions to be removed. So this will increase your ADR detection rate. And obviously, because of those things, the patient willingness to come back to have a repeat procedure, which is critical in surveillance, is better with water.
But I'm talking about preloading knowledge in the training journey, if you like. So I think there's a real opportunity here to modernize and improve our training, to accelerate training, and to have trainees who are better trained at the end of their journey. Now, hands-on training is very precious. Okay, so we only have so many moments to do this, and there's a lot of competition. Now, you never hear a trainee say they have too much hands-on training. You never hear a nurse say they love long training lists, especially when they finish late. You never hear a patient say they loved having a longer procedure than they needed to have. You never hear a trainer say they love explaining things the trainer should know already. And you never hear a manager say that they want to have more training lists because it interferes with the productivity of the unit. So there's an issue here. Now, what do I mean by preloading knowledge for hands-on training? Well, what I mean is that the trainee comes to the hands-on training with the knowledge required for that procedure relevant to that stage of training. And during hands-on training, the trainer is assessing the application of that knowledge instead of providing the knowledge. Now, what sort of knowledge are we talking about? Well, we're talking about knowledge that's described in curricula, and we are describing the sort of knowledge that we have on our GIEQs platform. Now, when we're training colonoscopists, we have three things that we're basically doing. We're teaching them to get to the cecum, we're teaching them to see everything, and we're teaching them to remove polyps. And I'm just going to illustrate the pre-knowledge sort of concept with each of these requirements. So here I am, I'm watching a trainee, and the patient's complaining of some discomfort, and I stop the procedure. What should I do as a trainer? Now, a lot of trainers will take over the scope because the patient's uncomfortable. Some trainers might just say, push on, and we'll press on the abdomen. Some trainers might say, well, what's going on? Why do you think you've got a problem? How do you think you can solve the problem? And that latter approach is probably the best approach, but it's also very time consuming. And getting information out of the trainee at this point is very much like extracting teeth, and it takes a long time. And if you're having a long conversation with the trainee in the procedure, you don't really have so much time for them to exercise their skills. So imagine a different scenario. And I'd like the trainees listening to this to go back to the recording and maybe write down everything I say. And when they go to the next training episode and they see this pattern of the scope guide, they might just regurgitate what I've said and see what happens to the trainer's face when you do it. So imagine if you said to the trainee, okay, you're not progressing, what's the problem? They say, well, the first thing I like to say is the scope is in the splenic flexion. I know that because it's pointing to the right and on the green screen, and it's pointing forward on the left screen, on the blue screen, I mean. And the other thing I see is that there's quite a tight angulation there. And for some reason, I'm not advancing the slides here. Oh, here we go. So we're at the splenic flexure. And the problem is we've got this tight angle here, and all the force is going up into the diaphragm instead of round into the tip of the scope. And the effect that this is creating this bulge anteriorly. So this is anterior and this is posterior. And I think the best way to mitigate this bulge is to apply some abdominal pressure, but we note that the patient's lying on their left side. And it's not very easy to apply pressure here when the patient's on their left side. I want to put the patient on their back, and I want some pressure below the left costophrenic, left ribs. And what I'm going to do is I'm going to pull the scope back, put the stiffener on, and I notice there's a bit of a bulge here as well. And I know that if I put a little bit of clockwise torque on, I'll mitigate that bulge. And then I need to go forward very slowly and de-angulate the scope, and I'll go around the splenic flexure. Now, you can imagine that a trainee coming to this problem with that sort of knowledge, we're going to progress a lot faster, and it's just a knowledge thing. It's not a technical skills thing. So as well as improving efficiency, having knowledge readily available reduces the cognitive load on the trainee so they can concentrate more on their technique. What about withdrawal? Well, I must say, fed up sometimes explaining to the trainees on withdrawal what position the patient needs to be in. And I would like them to have this diagram in their head and just automatically do what's required rather than be prompted by me. What about polypectomy? Well, this is one of my favorite slides I put together about 15 years ago, explaining that the journey to a polypectomy involves certain competencies. And these are skills, knowledge, judgment, and skills at removing polyps. But actually, in each of these steps, there's a knowledge component. And do you really want to be explaining all the knowledge at the point you're doing the polypectomy, or identifying or characterizing the polyp? Or would you like the trainee to say, well, okay, Sir Dr. Valori, I see a polyp there, and it's a very interesting polyp because it's got a little nodule on it, and the morphology of the nodule looks slightly different from the rest of the bit. And I'm sort of wondering what this is, but I can't see the full extent of the lesion. Excuse me. So I'm going to put a bit of dye in, and now I can see the lesion very clearly. I can't quite see the far end of it, but this looks like a sessile serrated lesion with an adenoma in it. And we call this a sessile serrated lesion with dysplasia. And I have to really be careful about removing this, and I'll probably use a hot snare rather than a cold snare. So you can see that the process in the training, with the knowledge that the trainee is bringing to the training episode, will really accelerate the whole exercise. And there's no reason in the world why the trainee should not come to the polypectomy and the identification of polyp without that knowledge. And here's another example of a sessile serrated lesion with dysplasia, which a very competent locum endoscopist in our service didn't see in the cecum. And I did this procedure about a month after his and found this lesion. It's a very important lesion to recognize. So I'll just take the theme slightly further. Knowledge is easier to assimilate and remember when it is relevant to the moment. So it's more difficult for us to think about knowledge that we're not going to use in the immediate future. So there's something about timing the knowledge acquisition to the need. And a case can be made to familiarize the trainee with the working environment beforehand. So what I'm talking about there is I have a vision that, say, for upper GI endoscopy, we don't require them to know too much to start with, but we give them a bit of experience of endoscopy so they know what it's like, maybe 30, 40 procedures. Then they go away, they look at the entire upper GI curriculum, they learn all the knowledge, and then they come back a couple of months later, only when they've demonstrated they've got that knowledge. And I would predict the whole training experience will be better, faster, and more effective. There's a EUS trainer in UCH, a card-carrying educationist called Gavin Johnson. And when I was talking about this with him, he teaches EUS. He says that he has experience of trainees coming to him with knowledge and with no knowledge, and he can train the guy with knowledge in a year, and the guy without knowledge, it takes 2 years. So where do you find the knowledge? Well, guess where? It's all here. And I encourage you to think about this for both trainers and trainees. So what does the future look like? Well, I think the future is really the trainee being instructed prior to the next phase of training what they need to learn before they start the next stage of training. And I think the trainers need to be more disciplined of this and make it very clear to the trainees what their expectations are. And in an ideal world, my vision is that we would have some sort of assessment process before the trainee is allowed to go on to their polypectomy, before they're allowed to start their fellowship with Pradeep to do advanced EMR, etc.
Yes and no. I would say you still, if you are going to withdraw and you're going to do withdrawal, you need adequate distension. And I don't think I'm keeping the mucosa, the lumen rather narrow to allow the endocuff to pull it apart. It's more that when you get into a space and you're finding it difficult to interrogate behind a fold, what you can do is just go down, adjust the tip, pick up the fold, and then with the tip in the downward deflection now pull back, and the cuff will engage with the fold and allow you to see the back of the fold. And I'm just going to bounce over the top of it in a moment. You see? And you see behind the fold. So it's not that you're not inflating. You certainly distend the colon, and that I think is a critical part of an adequate withdrawal technique, is adequate distension of the colon. But you're using the cuff really to manipulate the folds to enable you to get a greater visualization of the surface of the mucosa. No, you need to manipulate the tip, Michael. So I'm working quite hard here using the left-right wheels. I'm also adding a little bit of torque. We're going to put the fluid down to 6 o'clock, and we're going to try and aspirate the fluid.
So can you show us the corkscrew movement and how can we have a look on your hands as well?
Yeah, sure, for sure. So I hold the scope in a very neutral position. So the scope's lying effectively flat and horizontal, which allows my thumb to access the wheels, and this gives you exquisite tip control. You can see I've got what we call a nice C shape. So when I apply torque, you get a very nice one-to-one movement.
So first of all, can you explain the advantages of the endocuff above the transparent cap on the tip of the scope? One, and two is that I think you're doing a sedated colonoscopy, yeah, with propofol. Is that the reason you're not changing the position of the patient, or?
So I'll answer the first one first. Yes, it is. We're going to put the patient on their back, but we're probably only going to be doing one turn, Evelyn, just because it's quite a challenge.
Yeah, but that's the one of the disadvantages of propofol sedation. I think we should stress.
Absolutely. So the difference between the two distal tip attachments is I think they're useful for different things. So I think the clear cap is very good for establishing a fixed distance from the mucosa. So it's great for mucosal assessment because you get a fixed focal length. It also gives you stability when you're doing therapy. So in fairness, most of my practice is therapy, not surveillance. So I use a cap virtually in every case that I do. Whereas the cuff, yes, it does give you some stability if you're doing therapy, but it's largely a device for opening and pulling things away. So its role is exclusively in surveillance rather than therapy.